In the room today. Dr. Yeoman is back with us today. Thank you so much for taking the time to join us. I can see you're in clinic today, so we just steal you away for a wee while and then let you go back to your patients. Just a little bit of housekeeping before we start. Please remember that these Q&As do not take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. So we'll generalise your question to support that. But if you do need help with a more detailed issue, please give us a call on the helpline. I'm also recording the session in Click Meeting here, which we upload to our YouTube channel. But the right-hand side of the screen, as you can see it as you're watching us, where you can see names and the questions, that's not recorded. So that's a bit more of a private space for the people that are in the room here. You'll have heard me just saying to Dr. Yeoman there that following the patient conference at the weekend, which was a massive success, 120 patients together for us for the weekend. It was great, but as normal we had so many more questions than we could take in the room. So what we've done is we've brought all the questions that were left over from the weekend and brought them into our weekly Q&As. So I'll be sprinkling them throughout the next few Q&As and amongst the ones that get asked live as well. If there's anything that you're waiting on that is urgent, please just reach out to us and we can prioritise that for you. So, right, let's get started with the first one. First two questions are connected, so I'll read them both out and then we can go from there. So, is there any difference between FibroScan and elastography ultrasound? My hospital does the latter. And then I saw the consultant for the first time last Sunday since diagnosis. He ordered a cholangio MRI. How does that differ from my FibroScan and ultrasound?
Okay, yeah. So basically, FibroScan is one type of transient elastography, which is a way of measuring the hardness of the liver, and you can also do that at the same time as a standard ultrasound, as an add-on to that test. So some centres are, if it's set up in a certain way, they might have decided to set up transient elastography on the ultrasound. Some would have done it via FibroScan. It doesn't really matter which one you have done. Both have their uses at ruling in or out the presence of significant damage or fibrosis to the liver. But where we have to be a little bit careful is if you've previously had a FibroScan and then you're having transient elastography done at ultrasound, the absolute values are slightly different. The machines are calibrated slightly differently. So the hardness readings that correspond with certain degrees of damage are slightly different. So it's better to have either of those than not have any of those done. There's no clear-cut comparison as to head-to-head which is better, although on average more people will have access to FibroScan, but we can't directly translate between the two if you've had a FibroScan before. But in essence, they're kind of measuring the same thing, which is the liver stiffness as a way of determining whether there's any damage to the liver. In regards to the second question about an MRI scan of the bile ducts, they're doing that probably because they just want to make certain that this is PBC rather than PSC, which is a slightly different form of autoimmune liver disease. So PBC affects the small and medium-sized bile ducts. PSC can affect all the different sizes of bile ducts, including the large bile ducts. So sometimes if you want to really exclude large bile duct problems, you do an MRI scan of the bile ducts called an MRCP. It's a completely different test to FibroScan or elastography done at the ultrasound, because it's measuring whether there's any scarring to the large bile ducts, which you wouldn't expect to see in PBC, but which you might sometimes see in PSC.
That moves on to our next question, actually, which is, can you have PBC and PSC?
Good question. I mean, there are variants or overlaps between the autoimmune liver diseases, but we don't recognize a classical overlap between PSC and PBC. They are quite different conditions, even though they both relate to bile duct damage. And so there's not usually an established overlap or variant of PSC, PBC. So it's usually one or the other.
Okay. And along a similar line, does having Gilbert syndrome adversely affect PBC and or can speed up the progression of PBC because bilirubin levels are higher?
Yeah. So really good question, this. I mean, so Gilbert syndrome is a genetic disorder. It's probably one of the commonest genetic disorders in the population. It can affect a few percent of people. And what happens basically is that you break down the waste product of red blood cells, which produces bilirubin, and you create more of it. Okay, What's interesting about it's not a sign of liver damage. So although in many liver diseases or liver conditions, an elevated bilirubin is a sign of liver damage, in Gilbert syndrome, it's not due to liver damage, and it doesn't result in any liver damage. In fact, in some people, it can even be beneficial. There's a lower risk of cardiovascular disease in people with Gilbert's compared to people who don't have it, for example. And it probably changes your lipid profiles, your cholesterol profiles a little bit as well. Where so it won't make your PBC worse. Where it becomes difficult is we sometimes rely on the bilirubin to give us a gauge of how severe somebody's PBC is. So if you look at the PBC risk scores, some of those include bilirubin, because in people who have more advanced liver disease from PBC, when the bilirubin goes up, it's sometimes a point at which we start to think about liver transplantation. However, if you're known to have Gilbert's before that, then you have to interpret the bilirubin very, very carefully. But your doctor should be able to do what's called a split bilirubin test, because the bilirubin elevation in Gilbert's is a different type of bilirubin than it is in primary liver disease of any description, including PBC. So medical professionals can help tease that out, but it can muddy the waters a little bit in terms of that assessment, but it won't make your liver disease any worse, far from it.
Great, thank you. Question around the crossover of fatty liver disease and PBC. So can you talk about the crossover of fatty liver disease and PBC, and how PBC is affected by fatty liver disease?
Yeah, another good question. So the thing is, I mean, PBC is a relatively rare disease of the liver. Fatty liver disease is a very common condition affecting the liver. So it's possible, if there's common disorders, the common disorders can coexist with more rare ones. So people can have more than one condition. So in that sense, what's the importance of having both? Well, in general, and this isn't exclusively always the case, but in general, if you have more than one thing that's irritating the liver, there is the potential for liver disease to progress at a faster rate than if you only have one thing that's irritating the liver. And so we see that on average, if people have more than one liver condition, that their disease might accelerate. However, in both PBC and fatty liver disease, we see some people who've had conditions that their liver test is sometimes quite high, but it doesn't translate into significant damage. So if you have both, it doesn't mean to say that it's automatically terrible, but it does mean that there is the potential for things to progress faster. So what becomes important then is, how do you manage both of those risk factors for progressive liver disease? So that makes it even more important that from a PBC perspective, are you on therapy? If you are, have you responded to initial therapy with Urso? If you haven't, are you being offered a second-line therapy? Have you had a fibrosis risk assessment to determine how much underlying scar tissue you have now? Then when you look at the fatty liver disease, are those risk factors being modified? Is it due to alcohol, in which case reduced consumption? Is it due to body weight gain? If so, how are you working towards getting that weight down, which might even include pharmacological therapies with the new weight loss injections and all sorts of other things as well. So I think if you have two factors that can cause liver disease, it becomes more important than ever to really make sure you're controlling both aspects. Some of those things are within the gift of the person who's affected by both those things. Other times it'll involve that partnership with your clinician on the right medical treatments and have access to the right advice around lifestyle measures to bring weight down, and making sure you're on the right medications for your PBC.
Great, thank you. There is a question later on, actually. We have touched on weight loss injections before, but we do have a question. I could just bring it now. It says, are weight loss injections safe with PBC? Now, we've chatted about this before in our Q&As, and there is a video about it, but I just thought, as it's been brought again, and it was brought at the conference, that it'd be worth raising again, Dr. Yeoman, if that's okay.
Yeah, so where weight loss injectable therapies fit within the management of chronic liver disease is still an evolving field. So until very, very recently, there was none of these drugs were licensed for weight loss in liver disease. As of a few weeks ago, the FDA in the United States have approved semaglutide injections for use in people with fatty liver disease alone. That hasn't yet been licensed in Europe or the UK, but it is likely to come. What those medications are licensed for, though, is they are licensed for weight loss management, because these drugs were originally developed for diabetes. those medications are licensed for generic weight loss outside of liver disease for certain groups of people according to quite strict criteria. And those criteria normally require the person to be under the care of a weight management service within your local organization, so health board or trust. So at the moment, they're not freely available for your GP to prescribe. They're not freely available for your hepatologist to prescribe, certainly not in Wales, and I believe not in England or Scotland either. So there are processes and, for want of a better phrase, hoops that you have to jump through to get access to those medications. When it's likely those therapies will be licensed in the UK for the treatment of fatty liver disease itself, then hepatologists will be able to prescribe them for individuals. So at the moment, it's a little bit of a grey area, and unless you're involved in a weight management service or you're funding these medications yourselves, because people can buy them themselves, that they're not freely available just yet. The other question is about whether they're safe to use in these conditions, and there's no good evidence yet that they are safe to be used in people with PBC, but at the same time, we don't see any specific reason why it would be harmful. And clearly, if you have a significant weight gain and that's causing fatty liver on top of that, there's a significant benefit to bringing weight down. Where we have to be a little bit careful in some patients with liver disease is that these weight loss treatments, they don't just make people lose fatty tissue, but you can lose lean muscle as well. So in people with more advanced liver disease, you have to be quite careful, because advanced liver disease itself can be associated with muscle loss, and that can lead to a loss of functioning and lots of health problems. On the flip side, if you haven't got advanced liver disease, then if you're losing that weight and you're maintaining some form of exercise to keep your muscle strength up, you might derive a significant benefit. So the only, I think, caution I would have is that people with quite advanced liver disease, you have to be very, very careful that these weight loss injectable treatments are not causing too much muscle loss. But there are still people with cirrhosis of the liver who will be using these medications, but you just got to be extra careful you're adhering to the right dietary intake, and people should probably have input from a dietitian in that particular circumstance. But for most people, I'd imagine they would be as safe as they are for people who don't have PBC, recognizing that any therapy has some side effects and some complications, and we're still learning about some of those ones from these new drugs.
That's great, thank you. I'm going to move to some questions we've got in the room here. So, question we've in is that Professor Jones mentioned coenzyme Q10 for fatigue at the conference. Is it okay to take that if you have cirrhosis?
I mean, those supplements are generally very, very safe. So cirrhosis is not a sort of single entity. There are people with cirrhosis who have very early cirrhosis, and there are people with cirrhosis who are more advanced, and there are people with cirrhosis who have features of liver failure. So I think it is always important for those discussions to be led with your local health professional who's got a bit more intelligence on the severity of your liver disease. So I wouldn't have a concern if somebody's got what we call medically well compensated cirrhosis, so that the liver functions good, the bilirubin isn't elevated. If things are a bit more advanced, you have to be a little bit careful with anything, just because drug metabolism can be altered. But for most people, it would be safe.
Great. I'm going to read the next question out, but bear in mind that we might have to generalise the answer, but I will read it out as it is here. I was recently diagnosed in June with PBC, and my FibroScan in August showed a stiffness of 11. At that time, my ALP and ALT were still quite high, but they have been steadily improving on UDCA since then. Could my FibroScan result have been artificially raised by the liver inflammation at that point? If so, is it possible for my FibroScan score to improve as my tests normalise? Or does a result of 11 always mean permanent fibrosis?
It's a really intelligent question. So if this person fancies a job with us, I'm sure we can find some work.
I love the questions we get from our patients. Our patients are well informed.
So it's a really high level of insight and understanding about the condition and the different tests that we use. So first things first, I mean, the timing of doing your first FibroScan with PBC is tricky. And I think, there's an argument to be made about doing it the minute somebody is diagnosed. But also there's an argument to wait a few months as well, because we know that the liver gets stiffer in PBC than it does in some other liver diseases, because cholestasis, or the holdup of bile, makes the liver stiffer than inflammation from other conditions. So the thresholds on tests like FibroScan to diagnose cirrhosis and PBC are higher than they are in fatty liver disease, for example. And so what that tells us is that when the bile holdup in the liver is very active, the liver can be very, very stiff. And if that improves with therapy, either Urso, beta-cholic acid, elafibranor, hopefully soon seladelpar, then you can, and I have seen the liver stiffness improve quite considerably. So 11 is some way away from a cirrhosis range, but yes, I have seen readings improve quite significantly. What is difficult at the first point of assessment is you don't know whether that slightly stiffer liver is due to the degree of bile holdup or the degree of scar tissue, or a combination of both. So in some people, they might see their ALP come down and it might even normalize, but the FibroScan reading won't change. And if the FibroScan reading doesn't change, then what it was originally measuring was all scar tissue. But at the same time, stability of scar tissue is still a success, because part of the therapy is sometimes the scar tissue will regress, it'll improve on treatment. But if it doesn't worsen from a point of 11, then the outlook should still be very, very positive, because it's avoiding progressing to cirrhosis, and the more severe ends of the liver disease spectrum is where we've really got to keep people away from. So, you know, if it comes down, yes, that's because it's improving the cholestasis or the bile holdup, and it was that was putting the liver hardness reading up. Whereas if it doesn't change, that means that it's just solely measuring the scar tissue. But at the same time, if you keep that static, that is still associated with better outcomes than seeing the liver stiffness reading continue to increase.
Great, thank you. We've got a patient who was just diagnosed this week, and I think it's wonderful that that patient is here with us today and able to put a question to you, so that's brilliant. Please reach out to us on the helpline as well if you'd like a chat, but I very much welcome you to the session. I was just diagnosed this week and I'm digesting the information at the moment. I am 36 and was told that usually the diagnosis is happening later in life. What do I need to expect being diagnosed so early in life? Additionally, I have celiac disease and on a strict gluten-free diet. Is there any attention to nutrients I should be aware of?
Yeah, so it's a difficult time, isn't it, around summer diagnosis? So much uncertainty. And I think where we have to speak in generics here, I know this sounds like we're sitting on the fence, is that we don't have access to all the information as it relates to you. But if we talk about general things, is that we do see people with PBC under the age of 50, very much so. What we tend to see on average is that PBC, when you're diagnosed younger, seems to be more what we call inflammatory, okay? And that means that it tends to have or be associated with a higher ALP level. Now, a higher ALP level on average can be associated with a greater risk of developing scar tissue formation in the liver, but that's not inevitable either. I see people with a very high ALP level who, when we do FibroScans, have relatively normal FibroScans or don't have progressive liver disease despite those high ALPs. So it's not inevitable. But what it speaks to is that in younger people, there is the propensity, and again, partly that's because when you're diagnosed younger, you're going to have this condition for longer. Because if an average life expectancy is 75, 80, and you're diagnosed at 55, you've only got a reasonable life expectancy of 30 odd years to develop the potential complications of a liver condition. Whereas if you're diagnosed at 35, you've got potentially 50 years. So there's a little bit of an element of age effect. So the younger you're diagnosed, you are going to be hopefully living with that condition for very many more years. But what it speaks to, and as doctors, it becomes probably even more important to get on therapies that you're responding to. It's important for everybody, of course, but in younger people with that longer potential for progression of disease, it becomes critically important that your condition is well treated, that you're started on initial therapy, which is usually Urso, that you're assessed at the appropriate time interval and you're on the right weight-based dose of Urso. Loads of information on the PBC Foundation site about that. There's a plug for you guys there. So yeah, I'm getting used to doing this now. And if you're not responding at the appropriate time intervals, is that you're considered for second line treatments. And I think a fibrosis risk assessment is really important, not necessarily at first diagnosis, but certainly within the first 6 to 12 months, to establish a baseline level of liver hardness that can be used to monitor going forward.
Yeah, I'm going to just show, I've got some of our literature here as well. This one's a really good one. This is a discussing PBC with your clinician. So that's to know what to expect at clinic, and just as Dr. Yeoman was talking about there, the different stages in terms of first line and then second line treatment. I would say, speaking to other patients as well, I was also diagnosed at 36. I'm 54 now, so please reach out to us. We're happy to have a chat. I'm more than happy to arrange a little chat, and we can go through things. Also, just to make sure that you know what services that we provide and what other things you can touch into. From a mental health perspective, it can be a lot as well when you're newly diagnosed. So we've got things that we do regularly on a weekly basis. For instance, we've got Choose Me Tuesday every Tuesday with Cheryl, where we bring patients together to talk about self-care and well-being. So please reach out to us for a chat if you haven't done so already, and we'll make sure that you have everything you need.
There was a second question, I think, from Barbara as well, wasn't it, around that? And
there was, yeah,
around the celiac disease. So it's quite common. About 40% of people with one autoimmune disease, namely PBC, will have a second. Celiac disease being a very, very common co-associated condition. What would be really important for Barbara would be to make certain you have a bone density scan as well, because PBC can be associated with bone loss, particularly if you've got more advanced liver disease. But if you have celiac disease, which in itself can be associated with bone thinning, so that's osteopenia or osteoporosis. If you have a double whammy, a little bit like if you have two conditions affecting your liver, you can get more accelerated problems. And so it'd be really important that you have a bone density scan to assess your bone health. Some areas use a FRAX score before a bone density scan, but generally speaking, if you've got two risk factors, your FRAX score will be high and they'll direct you towards a bone density scan. The other thing in the short term is, if you're not already on it, calcium supplementation. You may need to be prescribed from your medical professional, but actually in the meantime, lots of calcium in your diet. So that it might be milk, it might be cheese, yogurt, other dairy products. Weight-bearing exercise is really important if you've got risk factors for bone thinning. And I don't mean lifting heavy timber or heavy weights. It can just be simple as any weight-bearing exercise, walking, brisk walking, reasonable inclines, things like that are really important to maintain that, and to avoid or stop smoking, because smoking is associated with progressive osteoporosis independent of having other risk factors. So there's some simple things there that can be done in the short term to make sure you've got the right calcium intake in your diet. And if your bone density scores are okay, then you can walk back from that. But it would be useful to begin with to make sure you have plenty of calcium in your diet.
That's great, thank you. I'm going to move back to the questions that we've got sent in at the moment.
Yep.
I'm just reading that one that's just come in, Dr. Yeoman. So it's a follow-up from the one about diagnosed in June and FibroScan in August.
Yeah.
It says, thank you for answering. In my autoimmune profile, I tested positive for AMAM2, which my specialist said is consistent with PBC. The same panel also picked up an SLA antibody, which was mentioned to me, but I was told my overall blood pattern still fits PBC. I know SLA is often linked with autoimmune hepatitis, which worries me. Could you share your view on how significant SLA is when it's alongside AMAM2, and whether you see it as something to actively monitor or more as a background finding?
Yeah, really good question, and not an easy one to tease out really without a lot of additional information. But if we're going to talk about generalities, so the M2 fraction of the anti-mitochondrial antibody is highly specific for PBC. So in general circumstances, you would largely consider abnormal liver tests to be due to PBC in that situation. Mm-hmm. When people have an autoimmune disorder, they often have multiple autoantibodies. They can have ANA positive, they can have ENAs positive. SLA is one of them. So SLA can be, again, quite specific for autoimmune hepatitis, but when you already have another specific autoantibody for a liver condition, it's not uncommon to get others. So it sounds like your clinical team, from the way you framed the question, have already considered this fact in light of other features, namely your liver blood tests, and have considered this to be more likely to be PBC related rather than having a PBC autoimmune hepatitis variant or overlap. Now, how do you truly distinguish between those two? The answer is it actually can be very, very difficult. Even with a liver biopsy, you can't always completely differentiate, because both autoimmune hepatitis on its own can cause some bile duct features. PBC on its own can cause some what we call interface hepatitis, which is considered to be the sort of classical feature of autoimmune hepatitis. So even a biopsy is often not completely specific for one or the other. So it can be very, very hard. So if the liver blood tests are much more suggestive of PBC, then the usual approach is to treat for PBC. You usually treat what you think is the most predominant pattern, and if it responds to that, then you've kind of got your answer. If it doesn't, then often the clinician will think about doing a biopsy to help provide some additional information to try and differentiate whether this is looking a bit more like an autoimmune hepatitis rather than the PBC. But it sounds like your clinical team have already thought about that in light of more information than they've got than we can see, and that it sounds like they're making rational or reasoned decisions for you based on that. But the important thing is monitoring now to see how you respond to treatment, and make sure you have that regular follow-up with them.
Great, thank you. There's a question came in the chat here, which I also have a couple of questions around on the list as well. So the question in the chat is saying, can you explain the side effects of the Urso drug, and can I expect body or mental changes from the treatment? And we've also got a couple of questions that were on the list, which was asking, will I experience any new side effects if I change my brand of Urso? And also, are you likely to develop side effects of Urso years after taking it, or do they tend to only occur when you first start taking it? So a few questions around Urso.
Yeah, I mean, Urso is a synthetic form of a naturally occurring bile acid, and it works by effectively thinning out your bile, making it less sticky and allowing the bile to flow through the scarred up bile duct. As a result, because it is synthetic, so it's always going to be associated with some side effect. Most of the side effects with Urso are associated with diarrhea. So, and actually that can often be mitigated or reduced by initially reducing the dose and escalating back up. Your body can often get used to it, and then that can improve over time. So the number of people that have to stop Urso because of side effects is very, very small. If you look at the literature, it can be 10-15%. In practice, if you're willing to consider stopping, restarting lower dose and escalating back up, it's very, very small percentages will have to stop because of that as a side effect. Paradoxically, we do occasionally see itching on Urso. So it's important to remember Urso is not a treatment for itch. And in some cases, a small proportion of people, it can make itching worse. So be wary of that. And if you do have itching, or if you didn't have itching and now you've got it after going on that, make sure you report that to your healthcare professional. We do sometimes see weight gain with Urso as well. I think something that I'm sure you come across this quite a lot, Mo, don't you, in the chat groups? And it is a reported side effect of the drug. It doesn't tend to be hugely significant weight gain, but it can be contributory in a subset of patients. But I think it's, again, you have to look at this in terms of the risk benefit of the drug. Generally speaking, the risks of the drug are very, very small, and the adverse effects are, generally speaking, minimal, but for a very small proportion of people, they can't quite manage even if they reduce the dose and escalate back up slowly, and they have to then be considered for a second line agent. So one of the indications for second line treatments in PBC is non-response to Urso at 12 months or intolerance to Urso, and that's an important thing to remember. So if you don't have to wait then 12 months before you go on to a second line therapy if you've been truly intolerant of Urso. But Urso is still a very good, very effective drug for many people with PBC. So we would like as many people who have PBC, who have a raised ALP, to be on that medication. And then the other new therapies, which do have more side effects. There's definitely more side effects in the other therapies. So this is why we really want to push the Urso. It's not just because it's cheap. We know how it works. We've got years of experience with it. And we know that it'll work for a really significant majority of patients. And if it does that, then we're doing so at low risk and low side effects, whereas the other therapies definitely do have a bigger side effect profile.
Yeah, and normally if someone changes their brand of Urso, I know sometimes occasionally we do get people getting in touch to say they've changed their brand of Urso and they maybe have stomach upsets or something as a result of that, and we ask them to go back and discuss that with their doctors. But is there anything to look out for in that? I think usually once you're on one kind of Urso, it would remain as that. It would only be if they're having an issue with supply or.
Yeah, it's an important one, this actually, and I think in general we should try and stick to the same brand that you were started on. There's lots of different, because it's a generic drug, it's produced by lots of different companies because it's off what we call patent. New drugs have a patent for about 15 years, and only that company that's produced that and owns that patent can produce that drug for that period. After that period, any pharmaceutical company can produce that compound. What is different between the different drugs is that it's not the active drug, will always be the same, but the constituent compounds around that, how it is absorbed, can be somewhat different. And for certain drugs, that can be quite significant. And so what it'll mean is some people might not have had diarrhea as a side effect with one brand, and they might with another. Similarly, there might be a slight change in response, not huge, but a slight change in bloods as a result of that, because it might just be that the absorption of the new compound they've been given isn't quite as effective as the previous one. And in those people, they might have responded to a really small dose of Urso, which is below the weight thresholds, and you wouldn't need to have changed that. You change the brand, it doesn't get absorbed as well, and then you might need a slightly higher dose of that one. So in general, stick to what you know, stick to what has worked, and if a medication you're tolerating and is delivering for you, we would be loath to swap that. Now, the last 5 or 6 years, COVID particularly was a big challenge, but in Europe particularly, issues with Ukraine, it also created some problems with supply for certain medications for a period of time. And there's other sometimes sort of economic reasons why supply chains can sort of fall apart. Sometimes your preferred brand isn't always available, and if it's genuinely not available, ask the pharmacist if it can be ordered in from elsewhere. But if it's a more widespread supply issue, then sometimes there is little choice but to make that switch. But if you're making that switch, report any change in side effects very early on, and make certain you're having a blood test done relatively soon afterwards to make sure it's still delivering for you. So it's not optimal, but sometimes you have little choice but to do that. But we do try to avoid it whenever possible.
Great, thank you. Just another question there on Urso. How impactful is the drug? And if you forget to take the tablets for a day or a week, or cannot get access to tablets because of travels, how would that affect the body?
Yeah, missing the odd dose is not going to make a huge difference, to be honest with you. The thing is with Urso as well is that, sometimes people prescribe it 3 times a day, some people prescribe it twice a day, sometimes, some people take it all once a day. I think, 3 times a day dosing is difficult. Remembering to take some in the middle of the day is hard. And there's good evidence from lots of different studies that the more frequently in a day you need to take a medication, the more likely you are to forget a dose. So it is perfectly safe. It's not going to harm your body to take it all in one go. And if that's the easiest way for you to remember doing that, that's fine. It just might be, you might be a bit more likely to get diarrhea if you just started the medication by taking all that drug in one go. So you're a bit more likely to get some of those minor side effects. Headaches can also occur with any medication. So if you get anything new by doing that, then you can always go back to splitting the dose. Urso doesn't work quickly. So some people will have a response within 3 months, but people in general, we tend to largely regard, don't we now, that probably about 80-90% of the response you'll have with Urso is seen within 6 months, but some people will have a bit more of a response at 12 months. So the reason why we have a 12-month review window is because it can take that long for the drug to work, and to have its maximum impact. What that tells you is it's not like steroids with asthma, where you take them and you feel better within a day or so. It's not going to bring about a day-to-day change when you're on it, and therefore it means that things are not going to relapse really, really quickly if you come off it. So don't be upset if you miss a day or so. I'm sure if we looked at all the people who have been responders to Urso and have got normal liver tests on it, I bet if you ask them how often they miss a dose, most people will say at least a couple of times a week. Okay, it's really common that people miss doses. Okay, and for many things, particularly drugs which take a long time to take effect, it's not going to have much of a material impact for you.
Great, thank you. Just as you were chatting there, you were talking about Urso for a year and then considering the response at that point, because we do have a question on the list that's asking about at what stage should you consider second line treatment?
Yeah, we kind of partly addressed that, isn't it? So certainly genuine intolerance to Urso, then you start the second line therapy straight away, you know, so that's pretty easy. You know, the guidelines say you should wait 12 months to assess the Urso response. I think it has to be individualized, you know, I think to some extent. And I think I'm not saying that everybody should have a second line administered at 6 months, but there will be selected groups of people, perhaps those who've got higher ALPs at baseline, for example, or already have significant liver disease at baseline, whereby, so what we're looking for in order to, when we say Urso has been effective, we're looking for an ALP less than, bear with me now, 1.67 times the upper limit of normal. It's a really weird number. For most labs, that equates to being less about 200, 210. Okay, ALP less than 200, 210, because labs have slightly different reference ranges. So if somebody's ALP is 800, it's not that common, but we do see it. And at 6 months of Urso, it's 500. It's not going to hit 200 in a further 6 months. It's just simply not, as long as somebody's taking that medication. So you can kind of extrapolate that, yes, you might expect to see a further 15, 20% improvement in that later 6 months. But if you're so far above that 200 rough crude threshold for determining whether you've responded to Urso, and you know somebody's got a higher risk for progression, younger age on average, or they've already got baseline significant fibrosis, then I'll start looking at second-line therapies at that point in time. So I don't think there's much justification for going earlier than that 6 month mark, but certainly I think it is, my view, reasonable to consider second-line therapies at 6 months if you have particular high-risk features. But absolutely, we should be doing that at the 12-month mark.
Great, thank you. Just talking about second-line treatment, we've got a question about the two new medications. Is there a difference in the outcomes with the two different PPARs? That's elafibranor and seladelpar. Yeah,
it's a good question, isn't it? And I think the jury's still out a little bit. I mean, if you look at the trial data, a slightly higher proportion of people on seladelpar normalize ALP. I'm not just talking about meeting that 200 ALP. Now, I mean, normalize it, and a slightly higher proportion will meet the primary response threshold of 200. But those are not direct head-to-head comparisons. They're two different studies, and there might be some subtle differences in the patients between those two arms. You look at the data, there doesn't appear to be dramatic differences between the two, but you aren't comparing exactly like with like. The only way you will know for certain is if you do head-to-head, you know.
Yeah.
So, and that's tricky. So I don't see those studies coming anytime soon. So I think at the moment, I think it's reasonable to largely consider them equivalent. At the moment, in the UK at least, only elafibranor is licensed, but we expect seladelpar to be so, because, you know, it is at least as effective, possibly marginally more so. But again, different agents will have different side effect profiles. And we see this with lots of different medications for lots of different conditions, whereby somebody will get a side effect on one drug, even within the same class. Mm-hmm. PPARs means that in the same class of drug, they work in the same kind of way. Some people will get a side effect with one and not the other. So I think it's a challenge for us as a community to identify which patient should go on to which drug, because it's not 100% clear yet which one is. What is evident is that each generation of drug, if you like, so if you think Urso was our first generation drug for PBC, OCA was our second, these are the third generation coming together. What we're finding is that each generation of drug, for want of a better description, is seeming to be more efficacious, and hopefully improving itch as well. And so I think at the moment, it's very much going to be a discussion with what you have available where you are, different jurisdictions. I know we often have people from all around the world on these calls. Yeah, there'll be different availability for different medical therapies as well. So it'll be a discussion with your local team about what is available locally that will deliver the best for you, because as doctors, we want to give you the drug that's going to be most effective to get you to where you need to be.
Great. A question about elafibranor is a patient asking how long it takes to get started on it. And I know when new drugs come in the pipeline, sometimes it can take a wee while, but the patient said it's been 4 months since been told they're going to start elafibranor, but it seems they've still not got it yet, and they're just wondering why the team at the local hospital can't prescribe it. I don't know which the local hospital is, so I don't know which area it is, but I have been hearing that some people are having trouble getting it in terms of actually fulfilling a prescription.
Yes, so this is a purely UK perspective now for people from outside the UK. New therapies for PBC have largely gone through sort of clinical networks, make a determination of making sure that it's appropriate, and also to provide a bit of a supportive network, because some people are looked after with their PBC by people who don't do a lot of liver medicine. You might live in an area where there's no hepatologist, for example, and you might have an excellent gastroenterologist, but it's having to do everything from inflammatory bowel disease to anemias to endoscopy, and so isn't as experienced in PBC management as people who purely do hepatology. So there are these networks in England, they call ODNs. In Wales and Scotland, we have these informal multidisciplinary meetings where almost like an application goes in for that, to make sure that people meet the criteria first and foremost, so the drug is being used appropriately, because these are new agents and they should be used according to their license, and then to make sure that the teams have the relevant information to make the right decision. These new therapies as well are also largely delivered by home care. Home care are companies that will deliver the medications to your home. There's lots of advantages to that, but they require contracts being set up between your local hospital and the provider, and obviously the pharmaceutical company. And sometimes, even though a drug is approved for use, so I think it was February, March for elafibranor, I think the full approval, I think it was February. It can take a month or two for those contractual things to be set up, and then it's a matter of, you might then not have been seen immediately, or then the paperwork has to go off, because goes through the operation delivery network, the MDT, for want of a better phrase, and those do unfortunately engender some delays in those processes. And some centres then insist on you being seen by that centre before they'll administer medication, so they can go through that with you. Others have a slightly different approach. So I think that can lead to some of those delays. So I can appreciate the frustration when you've been waiting for these therapies, but in reality, with lots of these things, they often take a bit of time to work their way through. But certainly within 6 months or so, I mean, I think we've started our first few people on elafibranor within the last 6 weeks, and it took about 3 or 4 months to get a combination of bits and pieces in place, which is frustrating for sure, but it's not uncommon for those reasons. So but again, please keep on to the team to sort of say, can they have an update about where things are at, so at least you can have explained what the particular issue is. It might just be that they're just waiting for the contract bit to be signed and for the home care company to get in touch and order the deliveries and stuff like that. But at least then, isn't it? It's not knowing is the worst bit. You know it's coming, you know it's in hand, you're not waiting for X, it's been approved, you're just waiting for specifics of the delivery and how it's going to get to you, etc.
And that extra information is really useful to understand why there might potentially be a bit of a delay as well. So that's great. And my favourite term is politely persistent. Keep being politely persistent to find out where things are. So that's great. Thank you. I'm just noticing another question just in the chat there. Any relationship between PBC and hair loss? I think that's been asked before about a side effect for Urso as well.
Yeah, it's interesting. I mean, if you look at the literature, it doesn't say there's a clearly established link, but we do see hair loss in people who have PBC, don't we? The thing is, hair loss can be an autoimmune. There can be autoimmune elements to hair loss. So, so it's very hard to tease out whether it's the generalized autoimmunity that lots of people with PBC suffer from. So people with underactive thyroids get hair loss very classically. So, if you have a coexistent thyroid disorder, that's probably more likely to be the cause. So I think all we can say is there does seem to be an association with having PBC and hair loss. Does it appear to be a specific thing? Not that we can identify, and there's not an easily treatable thing, but reported if it's there, because certainly checking thyroid function is important, because if your thyroid function, if your thyroid's underactive. You can lose it with overactive thyroid as well, but it's important to have that managed, because that's an easy win to manage that if it's a thyroid disorder. So yeah, there is a relationship, but the precise mechanism isn't quite understood.
I think always just not putting down things that are happening to your PBC. If you're having new symptoms or new things happening, it's important to discuss them with your doctor as well, isn't it?
Yeah, I think absolutely. And I think the important thing with that then is to always ask whether it could be, but also remember that not everything that will happen to you in the rest of your life will be directly related to your PBC. And it's important that people don't fall into that trap. And I mean, as hospital doctors and also as general practitioners, that we just say, oh, well, it's all related to your PBC, because it could be. It's important to ask the question, could it be? But for many, there won't be a clear association. And the reason that's important is that you shouldn't then just go, well, there's nothing you can do about it, because there might be something else that's lurking in the background that needs managing, that could be easily fixed.
Great, thank you. A couple of questions around other symptoms of PBC. Somebody asking is excessive sweating a symptom of PBC? Again, not a classical or a sort of clearly established one, but again, if you look, PBC will classically affect women rather than men. Classical ages are around that sort of 50 mark, and obviously menopausal symptoms can be quite common around that age group. So it's important to think, could this be menopause related symptoms if you get excessive sweating? I've certainly seen people with autoimmune disorders describe sweating, but we would never blame it on that without looking for other reasons first. So commonest cause in a woman who would be potentially of menopausal or perimenopausal age is to look at features around that. And then if there are other associated or worrying symptoms, investigation for other much rarer causes of sweats to make sure there's nothing more alarming. But certainly my first thought would be, if I see somebody who's well, who's got PBC, who's complaining of some sweating, is just, depending on their age, and menopause can happen early as well, and in some conditions can trigger an early menopause. So I think I'll always think about the potential for menopause. Obviously, if it's a man reporting that's not going to be quite so likely, but certainly you have to look down different avenues then. But certainly have seen it, but it's not a direct PBC thing. Another question's around, is bloating normal in PBC? Being told to try the low FODMAP diet to help with this, but after advised only to do this under the guidance of a dietitian. Yeah,
I think what's really enlightening is when you look at, we've said this before in a couple of these chats, haven't we, Mo? When you did your sort of word cloud of things that really affect people with PBC, it's remarkable how much pain comes out in that. As dominant as itching is very often in some of these surveys. Not everybody gets it. Those who get itch with PBC often get it really, 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 really bad. But there's lots of people who are fortunate and don't get any itch at all. So when you look at the totality of people who live with PBC, pain, bloating, discomfort are really, really common symptoms. And I think if you look at symptoms of abdominal bloating in any chronic condition, whether it's rheumatoid arthritis, whether it's PBC, whether it's autoimmune hepatitis, whether it's inflammatory bowel disease, common. And that's because gut dysfunction is common in chronic illness. So anything that makes you less well, anything that impacts on your general vitality, your mobility, can have impacts on your bowels. And even aside from having PBC, about 40% of the population will describe symptoms that are compatible with IBS at some point in their lives. So irritable bowel is an extraordinarily common problem in the general population as well. So it might just be that you've got IBS, which is a really common disorder, and then PBC, which is a not so common disorder. Nonetheless, if symptoms are new associated with changing bowel habit, they should be reported, or passing blood from the back passage. New symptoms like that, unexplained weight loss, should be reported to your doctor because they might require specific investigations. Most of the time things turn out to be okay, but should be investigated if you have additional associated symptoms. But bloating in and of itself is usually due to slowed intestinal transit, and that is common in people with chronic conditions. And the more fatigued you are by your PBC, the more it affects your vitality, your mobility, your general sense of fulfilling your daily functions, the more likely that is to have a knock-on effect on your generalized gut function. So it's like an indirect knock-on effect on your gut function by being less well and less active.
Great, thank you. We have a question about, is there a blood test for liver cancer that can be done periodically for people who have cirrhosis due to PBC?
Yes, but I think it's important to sort of contextualize that. So if you have cirrhosis from any cause, the current guidance within the UK and most of Europe and the US is to be doing regular ultrasound scans and doing a blood test called AFP, which stands for alpha fetoprotein. So alpha fetoprotein is a chemical that's produced by very immature liver cells, very immature cells. So if cancer cells are very abnormal cells and they don't behave like normal matured liver cells, which are very highly specialized, so they secrete these chemicals, and one of those is alpha fetoprotein. The problem is not every tumor secretes alpha fetoprotein. So, maybe only about 30-40% of tumors will secrete it to a significant level that can be considered helpful diagnostically, but nonetheless it should be measured regularly, because if it is elevated, not every time when it's elevated does it mean you have a tumor, but if it is elevated, then you definitely have to have more detailed investigations. And instead of having ultrasound, people usually go on to have either a CT or an MRI scan then to look for small tumors. So yes, blood tests are part of the assessment for the development of small tumors if somebody has cirrhosis. The other really important thing with this, although we talk about this and it does generate a lot of understandable anxiety, the absolute risk of any single individual with PBC and cirrhosis developing a liver tumor is still very small. Okay, it's just significantly higher than people who don't have cirrhosis. So if you don't have cirrhosis, the risk of liver cancer is very, very small indeed, whereas it becomes appreciably more if you have a chronic liver disease. And of the chronic liver diseases, PBC is one of the ones that has a slightly lower incidence. So we guesstimate it to be about 1% per year. So it's, that means 99 out of 100 people won't develop it in that given year. But it is important to keep an eye on that, and the guidelines do recommend that.
Great, thank you. I'm going to go back to another question in the room here. Patient asking, before my diagnosis, I was taking multivitamins and a statin. My enzymes improved after stopping them and starting Urso. Are supplements like these or statins safe in PBC, or should they be generally avoided?
Yeah, so supplements are interesting, aren't they? And I think, at the end of the day, supplements often called sort of herbal remedies or traditional remedies. Some of those things will have positive impacts, but many of them can have adverse impacts. Aspirin is probably a classic example. Bark of the willow tree, phenomenally effective drug for lots of different things. So that is a herbal remedy, really, isn't it? It's now synthetically produced, but it's a naturally occurring compound that can have lots of positive benefits. But the key thing is that has been studied in rigorous trials for both its side effects, safety, and for its effectiveness. The problem with most of the herbal, supplemental, natural remedy stuff is that the studies are usually very, very minimal. And certainly when you have a rare condition, the number of people with a rare condition who have utilized those medications will be very, very small. So there are a very small number of things. Milk thistle is one of those ones where it can sometimes make the liver test look a little bit better, but there's zero evidence it'll improve your PBC in the longer term. And it's best to stick to what is being well tried and tested. If people are very, very keen to carry on doing that, it's not my job to tell people what to stop, but there are certain over-the-counter and herbal remedies you can take. There are a few that can be damaging to the liver as well. So if we see those, we just say absolutely not. For others, it's probably not going to benefit you, and we just don't have evidence that it's definitely harmful. But again, don't start them at times of other things as well, because if you're starting a new medication for your Urso, don't start taking other things at the same time, because then you don't know what's causing side effects, you don't know what's causing benefit, or any other problems that might be coming along. So we tend to try and avoid them just because we don't have enough intelligence about how effective they are and how safe they are, whereas the medications that have gone through clinical trials are very, very rigorously tested. If you speak to anybody who does clinical trials, the checklist, anything that you report to a trial team when you're on a medical therapy and a clinical trial, everything has to be recorded. Everything goes down in the log. So when you see these enormous lists of side effects from drugs in the insert packet, those aren't all categorically associated with it or caused by that drug, but they're all things that have been reported in people who've been taking those drugs.
Mm-hmm.
So they've got a headache because they were just run down, and they've got a virus or whatever. But if they're on a clinical trial and they go in for a review and say, "How are you? Oh, I've had a headache," it gets recorded. And then what they try to do is try to collate those and try to see what the signals are about how common those things are, and if they more common than in people on placebo. But actually, the key thing is that try to avoid taking things that might muddy the waters, because the drugs that we utilize now are very, very tried and tested. We've got loads of experience of where the side effects are likely to be due to your medication, whereas these other things we often just don't know. So we're flying a little bit blind, and it's harder for us to advise you, and it's harder for us to establish what's making the improvement or possibly deterioration in your liver blood tests. So try to keep it as clean as you can is what we tend to try and do.
Great, thank you. And just before we leave that question, I just wanted, and we're getting to the end of the session, this will probably be our last one, but just touch on statins as well that was mentioned, because that does come up quite often for PBC patients as well.
Yeah, statins. I mean, if you need statins, and they're advised based on your what we call lipid profile, they've got lots of well-established and well-evidenced risk charts based on your age, other family risk factors, and your total cholesterol level, and the ratios of your good and bad cholesterol, whether you're at risk of cardiovascular and cerebrovascular disease. And the evidence is very strong that if you're in those risk categories, then taking statins benefits you much more than causing you harm. The risk of serious liver toxicity from statins is about 1 in a million. Okay, so at the same time, it's sometimes some people do start statins, have a mild reaction, and then you stop the drug or use a different statin and it doesn't come back. So in general, nothing is perfectly safe in life, but statins are very, very safe, and we're comfortable using them in people with liver disease. There's even been some studies looking at whether statins will reduce the portal pressure in people with really, really advanced severe liver disease. So this goes to show scientists have done trials in people with very, very advanced liver disease. That's not caused any harm. So yes, they can cause a bit of a flick in the liver tests. Serious liver toxicity is very, very rare. So we're very relaxed. As long as you've got a good indication for statins, then take them. And if you get a side effect on them, then it can be managed appropriately, but it's not a reason to not use them in the first place.
That's great. Thank you so much. We're going to finish up there for today. We've got through loads of questions today. Thank you so much for your time, Doctor, and we will let you get back to your patients again. But we'll be seeing you again soon, and we'll get this session uploaded to our YouTube channel as well so that we can watch on demand.
Well, lovely.
Thank you.
Good to see you, Mo.
See you soon. Bye.
Bye.